Ladies and gentlemen, it's my pleasure to welcome you to the special session on using technology to provide healthcare to all. We are privileged today to have an outstanding panel to talk on the subject. Mr. Omar Ishrak, it's a pleasure to have you in the session. You do lead one of the major medical technology companies in the world, a company that delivers technology solutions to healthcare providers in 155 countries. It's a privilege to have you here. Thank you for taking the time off, and welcome to you. Mr. Satish Reddy, it's a pleasure to have you today. You're a key leader of the Indian pharma industry, and your company has been a significant player in the global generics market. You have taken Dr. Reddy's beyond pharmaceutical inputs and made it a producer of finished formulations that are widely used in large number of emerging markets. Thank you for joining us, and a very warm welcome to you. Friends, healthcare is a unique industry, and in this industry, I think demand is never an issue, but affordability and distribution are always a challenge. We're lucky today that we have Omar, who represents one of the largest global providers in the med tech industry, and we have Satish on the other side, who's a very respected and a large pharma company, and both of them have revolutionized, their industries and brought technology and pharma which is affordable, which is available, and who've spread throughout the whole globe. So I think we're lucky we've got both of them. And I'm going to get started and let Omar make his opening comments, after which, we'll try and have a lot of time for questions and answers, because I think the interaction has been extremely valuable. And after Omar, I'd request Satish to make your remarks, and then we'll go in. Thank you.
Thank you, Preetha, and thank you for that introduction, and it's a real pleasure to be here. I had some slides, but I don't know if are they available to be shown, or I can just do without them? They will be? Okay. It's almost, in many ways, Satish perhaps should have been first, because medical technology in many ways lags behind pharma in its progression and adoption in India. And so many of the aspects that I'll present as a unique spin on medical devices, but in many ways almost unknowingly, if you look at the example of pharma, it's a track that in the end we're trying to follow, because the adoption of pharmaceuticals in India and around the world is in many ways way ahead. So with that, are we ready? I can do it without it. Yeah. That's fine. Yeah, that's okay. I'll do it with other things. So, what I thought I'd cover briefly is first sort of a general comparison of the healthcare systems in India and in the US. And from that, try to sort of analyze the respective strengths and see how the two types of strengths can be leveraged to provide better healthcare, actually not only in India, but facilitate some improvements here in the US as well. So, with that, okay, great, thank you. Thank you. Okay. So there we go. So if you look at the US, despite what some people may feel about the criticisms that one hears about the U.S. healthcare system, it is one of the best in the world. If you want quality care, high quality care, and you can afford it, there is almost no other place in the world you want to be in. And part of it is because even though there's a lot of complaints about access, in the end there is, in relative terms, pretty good access to healthcare in the US. And if you really need something, you'll get it here. Maybe not always in the same place, but you'll get it. And you'll get paid for it. Someone will pay for it. In addition, you'll probably also have access to leading edge care, which is really pushing the envelope. where, in many other countries where you can get more general care, the absolute leading edge care may or may not always be accessible. There is a tremendous research and innovation capability in the US, and as evidenced by all the medical schools, the universities, the technology companies, the levels of innovation, and we really are pushing the envelope in so many ways in advancing healthcare. This is a quest that will never stop, because our common desire to improve our own health, no matter who you are, will never go away. And our ability to understand the human body continues to grow, and our levels of technology also continues to grow. So you put the two together and the common desire for improved health, that is a journey that will never stop. And in many ways, the US is in the forefront of that journey, although there clearly are areas where other countries lead as well. Now, having said that, the cost of healthcare in the US is extraordinarily high. And I won't go into the details of that, but I could probably spend an hour just talking about why that is. Although in simplistic terms, it really is because we have a very fragmented system with no clear levels of accountability for true patient outcomes. And it's something that I think many stakeholders in healthcare, including the policymakers, recognize. But it's one that, it's tough to change, because they're entrenched stakeholders. And the process of change is slow and cumbersome and not geared towards rapid focus on patient outcomes for a variety of reasons, which I don't need to go into right now. So those are essentially the challenges, if you like, of the US healthcare system, as well as its benefits. Now, if I move on to India, it's almost the reverse. India actually has centers of excellence, like some of the institutions that Preetha leads and others, where you really get very high quality care. But I think everyone will agree that these are, in the context of the country and the size of the country, really only pockets of excellence. The vast majority of people in India are underserved in terms of healthcare. However, if I go back to some of the advantages of the Indian system, believe it or not, the patient pay system, and although I think some levels of insurance and reimbursement should be put in place, but there is a value to the patient pay system in that it drives high degrees of efficiency and accountability on the part of the healthcare providers, because the patients are essentially consumers. You don't always want it that way, because you want most patients to have the right to good health care. But at the same time, that level of accountability drives some levels of competition and efficiency that otherwise wouldn't exist. The other thing that India has is simply its size. There are large patient cohorts. It's a place where you can do studies. Not only can you do studies, but through practice, healthcare gets better, because you do more procedures than anywhere else, and you do them more often. And most of these procedures, which are often surgical or other interventional procedures, you get better if you do more. And even if it's not that, you get better at diagnosing if you see more. So the volume and the size of India has all kinds of advantages, which I'll share with you in a minute. Now, the challenges. First of all, the overall spend in healthcare is alarmingly low. I mean, less than 2% of GDP is not something that any country deserves. Now, whether it's government funded or private funded, that's a secondary question. The point is that I think everyone will agree that enough money is not being spent. And so investments have to be made in healthcare for India. And I'll come to that point a little later in more detailed terms. Now, in addition to that, there is an inadequate referral system. There is no an established system of primary care, secondary care, tertiary care, a system through which people can go to a doctor and depend on the right type of diagnosis and then referred to the right place if they cannot properly diagnose or treat. That type of system is at best haphazard and often based on personal views and opinions and referrals from friends as opposed to the medical community. That is not a way in which you can develop a healthcare system. So a referral system needs to be developed. And then finally, although the patient pay system has its own benefits, in the end, that's not a scalable model. And you need some level of insurance or reimbursement that is greater than what it is today. The systems like that have to be developed. Probably more government spending on healthcare, or at least some level of private industry or insurance company investment is probably essential for this type of system to scale. Now, if I put all of this together, and I just look at the Indian system and the US system, and just ask ourselves how we can help each other, well, you know, in summary, the US can actually help with the development of a systematic infrastructure because we have experience in doing that. We have experience in developing an infrastructure for healthcare, which is well established here in the US. We know we have physicians, and we can train physicians. And training physicians, especially with India, I think the US is particularly well placed because of the large number of Indian physicians who actually are here. I recently spoke at the American Association of Physicians of Indian Origin. And, you know, there's a large number of members of highly qualified physicians. I spend a lot of time talking to key thought leaders and practitioners of medicine in the US, and I can tell you a lot of them are of Indian origin. A fact that you may not know, but over 60% of medical school students and graduates over the past few years are of Indian origin in the US. So there is a natural tie there. And that tie, could lead to training. There's a lot of people, a lot of such practitioners in the US who want to do this, but don't have a system to depend on so that their efforts can be scaled in a way that makes a difference. It instead becomes a one-off visit to their relatives or whatever, and then do some sort of voluntary work, and they feel good about that, which is great. But if you could only channel that energy in a more systematic way, you could probably achieve a lot more. And then finally, although I'd be the first to say that the US healthcare policies are not perfect, but we've got experience. We've got experience, and we're rapidly trying to innovate and make it better in a fairly large country, although nowhere near as large as India, but large compared to many European countries and other such countries. It really is one of the largest delivery systems of healthcare there is in the world, given the fact that we've got high levels of access. And so there is experience here with respect to policies and what works and what doesn't work, and what one should avoid. And translating that to help India in its own progression is something that the US can help with. India, on the other hand, because of the reasons that I stated before, has actually high degrees of efficiency. Accountability, a system through which, and there are many examples in India, a system through which continuous improvement in the delivery of healthcare has been made because it's been forced, because of competition on different healthcare providers. And the levels of efficiency are much higher. The decision-making capability is much quicker. Groups of doctors can get together and make decisions. Now, that's good and bad. It's good in the sense you can make decisions, but in many ways that happens because the regulatory framework is weak. And so, bad decisions can also be made. So, the right balance needs to be found, but I do want to stress that there is experience of moving healthcare forward in India amongst the providers there in a large number of cases. And then finally, the point that I made before about the patient pools that are available in India. Not only is there a need just to localize some of the data, but beside that, on a more generic level, acceleration of clinical trials, and just improving healthcare by sheer practice in volumes, that patient pool concentrated in one place, that the demand is there, that's not easily available everywhere else, especially when you link that with the pockets of excellence, which are not like one or two, but many. It's just small compared to the size of India, but certainly not small in absolute terms. So I think these provide a framework through which we can think about collaborative models. Now, the important thing about collaboration, though, as I think Mr. Pilot pointed out, that India is a very complex country. It's a big country. And there isn't going to be a magic switch that we can flip and try to do everything in one fell sweep because of all the points that he made about the complexities, the differences, and so on, and the variety of maturity in different populations. So, one guiding principle that we're trying to sort of follow is that let's start with a community in a region and build it out end to end. Because true value in healthcare is achieved when patient outcomes are actually improved. Value in healthcare is not achieved simply by doing diagnosis. You have to have the entire infrastructure, because if you simply diagnose and then you don't know what to do with that patient, I don't know if that really, it may achieve something, but it doesn't achieve a lot. So going end to end, all the way from screening to diagnosis to treatment to post-acute care and follow-up is what creates value in healthcare. Something that's not only financially valuable, but it's valuable from a patient perspective, because that's why the population enters the healthcare system. So selecting a partner with whom you can build out this end-to-end model, and that could be a provider, it could be a government, it could be a region, it could be a community. But it has to be something that's holistic, and a partner who is committed to providing that end-to-end solution. Second, healthcare is complex. It's very complex. It's not even fully understood. All the nuances of the human body and all the different conditions that happen. It varies per person, you know, and it's good to look at averages unless you happen to be the outlier. So you cannot take healthcare very simplistically. It's not necessarily a consumer type market, because the penalties for making a mistake are massive. And so you have to be very careful. And the knowledge base is unique. It has to be developed because it truly is unique almost to an individual. Now, that doesn't mean that there aren't groupings and cohorts and so on, but it has to be done with a certain thought process in mind. And because of this complexity, and because of the line of sight to outcomes, it is better to select diseases, specific diseases, and go deep in them. And make sure you move the needle in that disease rather than try to do all diseases in one shot, because, you know, it's different. And every disease actually is quite complex. So given these two sort of guiding principles, here is a proposal that we're trying to work on that, you know, it's certainly not simple, but is a starting point. And we call that the hub and spoke system. It's almost obvious, but it's one that could do with some development. Now, I know that you know, Apollo hospitals, for example, and others have similar thought processes, but if you link that together with cooperation and collaboration from expertise that resides in the US, you could probably accelerate some of this. Very simply put, a hub and spoke system is one where you have a hub, which is a place for advanced care, and advanced is relative, but it's, you know, one that you know, probably does surgeries and fairly complex procedures. And then that hub is serviced by spokes. And those spokes are, in the beginning at least, diagnostic and screening centers. And you need them simply because of the scale and breadth of the geography of the country. That you know, you simply cannot expect people to show up at hubs. You need to have these collection centers. And you cannot have too many hubs, which are very expensive, which, you know, a mistake that exists in the US, where, frankly, there are too many hospitals. In the US, you know, even in the US, believe it or not, if you talk to the HHS here, the Health and Human Services Office in the US, they'll tell you that one of the biggest problems here is actually the rural population in the US. And I think at least this audience realizes the rural population in the US is like a little a little grain of sand compared to what it is in India. And so, you know, having this kind of a spoke system is essential to reach the levels of population that exist in that country. The trick here is to connect the spoke and the hub, and build a referral system in between, and each spoke and each hub understands their complementary attributes that they have in this path. What we can do is to help the training process. Help the training process, help the infrastructure creation process in both the hub and the spoke. Of funding if necessary, but more importantly, establishing the right types of technologies and capabilities in both of these centers. And trying to use our general knowledge of referral systems and policies to apply to these hub and spoke systems. So again, a simple concept, but a focus has to be there in trying to attain it, and a clear goal has to be made, has to be there as well. A disease focus, I think, is essential, and I'll talk about that more in a minute. Again, a hub where a particular disease, say for example cardiology, is a specialty, and spokes where cardiology, diagnostics, and so on are the specialty by themselves. Now, if you take this to the next level, once the basic center is established, you can really then pick it up to a point where the relative merits of the two systems can really be leveraged to create a real differentiator in India. And that is, if I start with the spoke, with the hub, what one can do is, as the system is established, elevate the hub to perform higher and higher and more advanced therapies and technologies. Take the latest leading edge stuff that's in the US, move them to India, because the hubs, like I said, they're pockets of excellence. There are doctors who are eminently capable of not only executing on those procedures, but even training others. At the same time, that'll free up their time from doing the standardized work, which can then be translated to the spokes. So in that way, the spokes also upgrade themselves. They do basic procedures, not only screening and diagnostics, and that frees up time from the hubs, and the hubs then go to the next level of therapy development, which then puts India rapidly as a leading edge provider of healthcare. Now, in addition to that, if you take it to the next level, take advantage of the size and scale. Use the fact that you now have these advanced centers of therapy and use them for future clinical trials for things that aren't even developed yet. And again, given the size and scale and the population of India, that becomes a very attractive model. And with the spoke, not only can you do interventional procedures, you now reach out to homes and do remote patient monitoring and do more preventive care and chronic disease management. And here are just some examples, which I think this audience is completely familiar with all the possibilities that can happen. But the warning that I have on this page is that don't start with that page, because there's no end of solutions you'll dream up of. But unless you apply them to a specific target, it'll be highly inefficient deployment. So start with the prior pages, describe the problem, select the disease, fix the infrastructure, and then do this kind of stuff. This is clearly there. But for a technology community, it's very easy to jump to the conclusion that you just, put a bunch of technology there and everything will be solved. Think of the problem first. And I think that's what I would say with respect to this page, which I think is most familiar for you. Now, I'm going to move on now to the next topic, which is kind of related. This is going to one level below in terms of care beyond advanced centers. This is an example that we've done for the underserved in India. And this is a fairly kind of a not very fashionable disease, but it's one that's extremely debilitating if you have it, and that's chronic ear infections. It is almost unheard of here. Yet in India, there are 80 million people who have untreated chronic ear infections. Small percentage of the population, but 80 million is nothing to, sort of sneeze at. And over 60 million of them are hearing impaired. So what we've done, for example, in a program is worked with a community to provide local healthcare workers who do the diagnostics, do simple screening, do simple treatment, and then refer them to a hub, which is in that local area, and the patient then gets treated in the hub for more complex procedures which may require other forms of intervention. This is a very simple model. The cardiology model is a scalable, well-known model which requires advanced training. This is a simple model. And the reason I show this is because this thought process of a disease and scaling it, a spoke and a hub, that concept can be applied at different levels. And in India, almost no problem is too small, simply because of the size of the population is so big that you can scale almost anything. I mean, there are countries with populations less than 80 million people. And so the fact that this is not only a business opportunity, but certainly a societal opportunity goes without saying. And again, this is one example. There are hundreds, if not hundreds of thousands of such examples that you can pick. But the important point here is to pick a disease and go end to end. Now, if I move on to the next subject, which is really about Make in India, I'll start with a statement that maybe not phrased correctly. I'm stating here that India as a center for global manufacturing for medical technology is not realistic, but more importantly, it's not necessary, and it's certainly not the priority. And if I follow the pharma example, pharma got established by serving India first. And for even Indians, to think about exporting technology out of India, when there's such a huge need in the country, I think is wrong. Because by serving the needs locally, you can create enough economies of scale that will justify manufacturing. You'll get us, as a global medical technology company, to pay serious attention to India if we can have a pathway to delivering healthcare in India, rather than saying that, look, it's so cheap and cost efficient, you can export it around the world. I can tell you, every government I meet tells me the same story. And they all have reasons. They may not be as big, but they all have incentives and this and that, and that they go put a factory there and you can export. Well, in India, you don't have to do that. Just serve your own people. And you've got plenty, big enough market. And if you have a line of sight to that, we will put a factory there, but not for export necessarily. I mean, that might come, but really to serve the Indian population by itself. And on that basis, partnerships, I think, are very important. And one such example that we've sort of looked at is working on cath labs. And really the partnership here is more about how do you provide access, how do you provide the training, very much like what I talked about in the cath lab example, except this one is a partnership that we're thinking of with some states in India, where the state makes available the government-run facilities under some kind of a PPP opportunity. The state does the reimbursement for care. That means pays the providers what's necessary. The state drives adoption. We provide the training, we provide the infrastructure, and through that we get assurance that the products that we put over there will be used. And if they're used, we will put a factory there. If they're not used, then we'll know why they're not used, and we'll go fix that problem first. So this kind of partnership, which the cath lab is an example, is one that we have to pursue. And the context I will give you is something that comes from a different country. If you take two examples, and I'll take Russia as an example, and I compare Russia because it'll give you the potential of what's possible in India. Here's an example of a country that's got 200 million people, like a fifth or less the size of India. Yet, there was a focus by the government to treat one aspect of heart disease, only one aspect, acute coronary syndrome. There's not even all heart attacks. It's just one type of heart attack, acute coronary syndrome. And the government said that, to kind of treat these patients, you need a certain infrastructure through which patients, when in a hospital, can get a stent put in a certain amount of time and the appropriate treatment provided. And the government we, together with the government, arrived at a partnership together with a third party that we would put a factory in Russia to make stents for guaranteed deployment in Russia for those instances, and we would help do the training and creation of that infrastructure within the existing government hospitals, as long as the government was willing to deploy the products that were made in Russia in agreement with them. Just that alone, remember what I'm talking about, a relatively small country in population compared to India, one small disease, believe it or not, the amount of the business opportunity that was apparent to us from delivering that was enough for us to justify a factory. Just one small disease in a small country, if scaled properly, is a big enough business opportunity. India is 5 times the size, and there's many more diseases you can treat. There's no end of opportunities like this. And by the way, there are more physicians locally available in India than there are in Russia, who are highly trained. And so this is the kind of thing that we can do, and it can be done. There's another example in China, which I won't dwell on, but very similar. We did this with a state in China, with a city, in fact, the city of Chengdu, relatively small population, but a willingness from the government there to do the deployment. If they're willing to do the deployment, we'll help with the training, we'll put the factory in place. If that isn't there and say just build a factory and export to the whole world, that doesn't make any economic sense for us or for anybody. And I'd argue that that's not the right thing for that country. Let me finish just by stating something that I strongly believe in. I mean, for a multinational like us, going to a place like India and making a difference is not an option. I mean, this is one of the largest, especially in medical technologies, one of the largest untapped opportunities that there is. 1.3 billion people, and even in the premium segment, a population who can literally afford to pay for the care out of their own pockets. even in that population, therapies that are well established in the US and other Western countries, well established for decades, are available to 5 to 10% of that population, not the entire population. So the opportunities are enormous, and then as you work your way down to lower and lower levels of the economic pyramid, sometimes doing it in parallel and sometimes doing it in serial fashion, this is undoubtedly, in my mind, the biggest untapped opportunity there is in healthcare, in medical technology. There's absolutely no question about it. And so it's a big opportunity and certainly a business opportunity, but more importantly, a societal opportunity and a responsibility for all of us. So with that, I thank you very much, Preetha, for inviting me here, and thank you very much for your attention, and I'll be delighted to take questions later. Thank you.
Very good afternoon, everybody, and thanks, Preetha, for your kind words of introduction. She's always very extremely generous in words of praise, so she and her sisters too, Sangeeta and Shomna, always very generous with your praise in the words of introduction. So I think it's a good thing that Omar started this presentation because he gave a good overview of the entire healthcare and also the framework for collaboration. So one, it saves me time. And I will also probably talk more from the pharmaceutical perspective, because you painted a very good picture of, how the healthcare system is very evolved in the US, what are the challenges when it comes to India, and what could be the collaborative framework by which things can be done, and few models. So I agree with most of those, right? So that's a good part. So my comments will probably be in two parts, right? So the first part, I also wanted to give a frame in terms of, so what happened in the past in terms of the evolution of the relationship between the Indian pharmaceutical industry and the US pharmaceutical industry. So if I wind back to almost, say, 30 years back, right? So that was the time, if you see it from the US point of view, it was like Omar showed in his slides, it is a high cost of healthcare in the US. There was an aging population. And if you look at the supply chain at that point of time, in terms of pharmaceuticals at that point of time, the active ingredients, the APIs, used to come in mostly from Europe and Japan. So those were the big suppliers of raw materials into the US, who would then finish and then sell in the US market. So if you see it from the Indian point of view, there were two defining moments, I believe, in terms of how the industry, came into being. The first was clearly in the 1970s. I would say exactly the year 1970, when the Indian Patents Act was promulgated by the then Prime Minister Indira Gandhi. What it said was that it won't recognize product patents, but it will recognize process patents. So this went on for almost 35 years, and that was a defining moment for the pharmaceutical industry. It spurned entrepreneurs. For example, our founder, chairman, and my father, Dr. Reddy, for example, he used to work in a public sector enterprise. He became entrepreneurial, started a bulk actives company, and in a very short span of time, looking at off-patent products, that's what we used to export into the US. That was the very beginning of how Dr. Reddy's started. But very quickly it moved on, into forward integrated into formulations, and then came the next defining moment, which is in the early 90s. That was the time India liberalized, Indian companies started looking overseas, and especially for a pharmaceutical company like us, in finished dosages and APIs, we looked at US as the biggest market, because that was almost, at that point of time, 60% of the world pharmaceutical market, and we decided to invest into this market. So that was the beginning in terms of, how Dr. Reddy's also made its move. So if you see what happened from that point of time, right, so it was then the opportunity which presented itself in terms of huge number of products going off patent in the US, and Indian companies, as an example, Dr. Reddy's, would then look at their process development capabilities, which is essentially chemistry skills. A lot of talent, very good manufacturing systems, high quality. So using these strengths, Indian companies then made their foray into the US generics market. What enabled the generics market in the US? There used to be, I think sometime in 1984, there was a Hatch-Waxman Act which was promulgated, which also in one of its objectives helped generic medicines to be to give it more penetration to the US. So that was that act in 1984. So if you look at these happenings and all that, just in a short span of time, what used to be in the early 2000s, generic penetration in the US, which just used to be about 50%, today it's almost about 88% generic penetration. So if you see the opportunity and translate it back to Indian companies, and that was huge. Just to give an idea of what it does in the US in terms of healthcare savings, right? So this is according to the Generic Pharmaceutical Association of India. They say that $250 billion of savings happened in the year 2014. Right? And if you take even 1/3 of that, because Indian companies, lots of them came after that, and they supply a huge volume of medicines, even if you take 1/3 of that, it's $80 billion of savings coming in because of Indian manufacturing. So this was a kind of opportunity, this is a kind of contribution that the Indian pharmaceutical industry makes, and that's how the whole evolution takes place. So this relationship, over the past 30, 35 years, was very, very fruitful in terms of the supply chain from the Indian companies, in terms of huge savings for the US healthcare system, also thereby enabling, savings. That's something which really worked out well. So let me go to the second part, which is, so how is it at the present point of time? Because in whatever I said so far, it was all about access to healthcare. It was about affordable medicines. That was really the story of the past 35 years. Even today, this issue of affordable medicines continues. It continues in India, it also continues in the US. So if you see the generic companies like us again, and various top leading companies of India, so we continue this story of the generics. So it's not just about products just going off patent. It's also about a lot of innovation which goes on there, specialty generics, so which have some level of intellectual property protection, which is important. And I know, Dan, that's a contentious issue in terms of how the US views it. But when you really see the evolution of the industry, it's moved up the value chain, right? So it's moved up into injectables in the generic space. It's moved on to specialty generics. And a company like ours in the past also was engaged in drug discovery, right? So in the year 1992, the lead which my father had taken at that point of time, we became the first company in the private sector to get into drug discovery. I mean, there's a significance to that. You will not find this kind of a business model anywhere across the world where you would find a company which pretty much started producing bulk actives and also just entered finished dosages, invest into drug discovery. Because, mind you, there's no grants coming in from institutes or from the government at this point of time, like it happens in the US. It is completely with the earnings which the company generated. So it's a big risk. It was a huge spend. And as it happens with the risk in drug discovery, that's something which is a model we had to change 10 years later after tasting some initial success. We actually had 3 products discovered by Dr. Reddy's, which were licensed to multinational companies. There was 2 to Novo Nordisk and 1 to Novartis, right? So that was the accomplishment, towards the end of the 90s. That's what Indian company was able to do. When everybody wrote it off saying that Indians cannot discover drugs, we actually proved it. But as it stands with the risk of discovery, there's a lot of uncertainty, there's a lot of risk. Some products didn't really make it through the clinical trials, and we had to change the model because we couldn't sustain almost spending 15% of our R&D costs on drug discovery, so we had to change the model. And then we now floated a subsidiary by which we did a collaborative model. So that's how we have taken the industry. Now, just like I said, right, at this point of time, if you see the challenges, companies have moved up the value chain. They're doing more innovative things. And then there are also challenges, right? So what you would really see in the news these days is big thing is really on the quality issues. There are some regulatory actions which the US FDA had done, but that's something which Indian companies are addressing and quite confident that within a year everything will be sorted out. So that's one level of challenge. There are also issues in terms of policy which tend to be very, very challenging. So that's something we're also grappling with, and that needs to really pan out. I'll just come to that just in a bit. So if we now get to the real topic, which says that from a pharmaceutical industry perspective, what could be the approaches by which we collaborate? I think broadly it's on, say, 2-3 counts. First, clearly, is on the policy front, right? So if I look at it from the Indian point of view, the amount of regulation that a pharmaceutical industry has to go through is absolutely stifling. So if foreign companies have not invested much into India when it comes to manufacturing or setting up, their R&D outfits, it's understandable, right? So some of it can relate to IPR policy that Dan talked about in the morning. And there is a point of disagreement when it comes to generic industry, which we also talk about, which is something to do with something called, I won't go into details, but it's Section 3D and compulsory licensing, right? So these are hindrances for US companies to invest into India. But there needs to be a clarity. I think the important point is if there is clarity on the policy framework, it can attract more investments, more collaborative efforts for multinational companies and American companies to invest into India. That's one of the issues from this side. I think from the other side, if you see from the Indian companies, I mean, there are also issues that we face because, as you know, Special 301 is one of the issues. Again, Dan, you're quite deeply involved with this. So this also is something like a sword which is hanging over our head, because if India were to concede too much on that particular front, it's all related to intellectual property, so I won't get into details. That again shuts the window for the generic industry. That's something we also need to sort it out. So a policy framework, I think, needs to be sorted out to create an enabling environment which would, help, meet the ultimate objective, which is access to affordable medicines. So that's one point. Second thing is just like the collaborative models that Omar talked about in healthcare, I think even in the pharmaceutical industry, there are several models which are available and the time is ripe to do that. So why would I say this? Let's take the strengths of both the countries, in terms of, where they can collaborate. Take it from the US point of view. This is the hub of innovation. The ecosystem that's created here, the kind of companies and the amount of resources behind research creates the most innovative drugs anywhere in the world, and it still continues. There are challenges in terms of, the numbers and all that, but this is still the hub of innovation. The question is, if you see it back in India, there are also capabilities. Like I started off saying, there are companies who still do drug discovery today. They're resource constrained because there's not really much support coming in from the government or from private equity at this point of time. So in terms of collaboration, there are plenty of ways of doing this. Right, just like I talked about, one of our subsidiaries, so we do a collaborative kind of research. So the early stage discovery, everything we do, and then we give up rights for certain countries when it comes to commercialization. And that's a model that's working. But that's only one company doing this. But if we are able to find networks by which this collaboration can, move on, it offers tremendous opportunity. So that's something on just R&D as an illustration. But then there are different segments in the pharmaceutical value chain where I think the collaboration can yield tremendous results. I think Omar also in his slides mentioned about, the huge Indian population, right? So when it comes to clinical trials and, the kind of patient population available, again, this is a policy framework. There was a time when, there was some controversy going on the clinical trials that everything came to an absolute stop. But I think good thing is it's being revived, right? There is some clarity, still some more things need to be done. But this can actually provide an opportunity for companies to collaborate and again, lead to the objective of, again, discovering drugs by active collaboration and really, take advantage of that. Because for the American companies, it would be, lowering of the costs. For Indian companies, it's to gain the scientific expertise. But the collaboration ultimately, I think, would lead to more innovation, more drugs coming in. So that's something which is possible. So just to conclude, so today, I mean, on just the healthcare point of view, there is a lot of disruption happening at this point of time. Preetha did talk about it in terms of what happened yesterday when we were at Google X. Again, Dan gave this example of, that smart contact lens. You're looking at a Google, which is from the IT sector, moving on to life sciences. That's something we never imagined, but it's actively happening in collaboration with a leading pharmaceutical multinational, Novartis. It's a disruptive thing what they're attempting. So if I take it back to India and then see what can be done, there is a classic example of a company called Narayana Health. Used to be called Narayana Hrudayalaya in the past, but this is a company, for example, in terms of the cardiac surgeries, right? What this hospital does. I mean, Wall Street Journal at some point of time titled the founder of this company, Dr. Devi Shetty, as the Henry Ford of cardiac surgeries, right? Almost like an assembly line. If you see the costs, for example, it's done at 1,500, compared to the US cost, which is almost 100,000, right? In terms of number of surgeries, almost, I think, 30 plus per day, when it comes to just 2 or 3, when it comes to the US. And from that 1,500 in India currently, they want to take it down to 800. And you're seeing this Narayana Health also establish, a hospital in Cayman Islands to also serve patients from the US, right? This is a business model. So how successful it will be, that's a different question, but this is how, a hospital chain has thought through. If you see the advances in technology, yesterday Preetha was telling me that Apollo does surgeries through robotics, right? So you're looking at that end of innovation, and you're looking at mass assembly line kind of cardiac surgeries. So this is the innovation which happened in healthcare. And then when you start taking it to the rest of the population, I wanted to quote Sam when he talked about it in the morning when he said innovation from the bottom of the pyramid, right? So you also need to worry about the rest of the population. How do you, in India, access this population? Because like we all said, it's like the spend from the government is very, very low at this point of time. Public health infrastructure is in shambles at this point of time. So it's really the private sector which takes on the burden. And then if you really see what kind of models work in this space, I just briefly, before concluding, wanted to talk about something that we tried, but this is more of a philanthropic effort, from a company. Thanks to Sachin, who's just left. But when he was the corporate affairs minister, this whole thing about 2% spend on CSR, was something which was made mandatory, right? So it propelled a company like us, which was already spending about almost 1.2% or something on CSR anyways. So it propelled us to also think in the healthcare business to see what we can do to spend that, right? So it was a philanthropic spend on the CSR side that we tried this experiment in Vizag, Visakhapatnam, where our manufacturing facilities are located, and there are almost about close to 80 villages surrounding it. So our model was that we need to take the healthcare to the doorstep. It's as simple as that. Because, like I said, public health infrastructure doesn't work. There are no doctors there. So we had to train community health workers, through one of our foundations, deploy them there, using mobile vans through a fixed day schedule. The villagers know that on at least 2 days in a week, right, at so-and-so time, that they're able to get access to healthcare. And if it's more serious cases, we would then refer them to the secondary care in the nearby towns. And that's something we worked on, right? But this isn't just an experiment. It's, again, on a philanthropic model. It's not a sustainable model because we can't keep funding it forever. But the question is, how can we scale it up and how can we take it to more villages? That's a challenge we have taken ourselves, but more on a philanthropic side. The question is, how can we then use it as a business model and also start working with the government through these networks of collaboration, also see models which work in the US, right, in terms of technology, in terms of how we can disrupt, to see that we not only just serve the rich, by providing better healthcare through disruptions and all that, but actually take it to the villages, right down to where it's required the most. I think that's something which, really appeals to my mind. So I just wanted to close with this. I think it's a tremendous opportunity as far as India is concerned. In the pharmaceutical space, plenty of innovation going on at this point of time, a lot of collaborative efforts possible, but like I said, clearly the policy framework has to enable this. That's what I sincerely believe in, right? So thank you very much. Thank you.
Thank you, Omar and Satish. They were truly outstanding presentations. Both of you come from two sides of the spectrum of healthcare, and I happen to sit in the middle. I didn't realize that till after you both spoke. One is pharma, one is devices, and I'm the provider. So I guess you guys have, you have the complete picture here. Having said that, I think it's all about access, affordability, many answers available, many answers found. But what I saw in Omar's presentation is that, from being just a purely devices company, he's moved it to value addition. He's moved it to really giving more than just being a manufacturer. And the same thing, Satish has also come out of the truly traditional background of manufacturing something and then being prescriptive. So I think somewhere the lines are converging, and we're getting holistic healthcare, which is, I guess, good for the rest of the world. So it is an evolving field, and it's always a challenge. And having said that, I think it's a great time now for questions and answers. Let's start with this corner. If you could just restrict to 2 questions. Sure. And identify yourself.
Hi, my name is Atul Kumar, and I've been in the healthcare industry for the last 7 years. One of the shortcomings I see, and there's a question to all three of you, in fact, is that we're very focused on curing a disease after it happened, but we are our very own Ayurvedic and other systems. I don't see enough investment. So do you see any plans or any opportunities for you as a businessman to invest in that?
Getting into Ayurveda.
So, frankly, we are not into Ayurveda. right? So nor do we intend to get into it because I think, see, in terms of our expertise, or if I broadly take the pharmaceutical industry expertise, it's like I said in chemistry skills, right? So when it comes to Ayurveda, right? So it's a different form in terms of, how that science is looked at because it's not purely just the product, it's a holistic system which works. So we don't know about it, nor can we claim that, that we can do something about it. So we definitely will not get into that space.
Comments on that?
Actually, I think that's an important point. A number of things just to be pragmatic about it. First, I know it's kind of in many ways, prevention seems to be a good place to invest. But I think, you've got to realize that virtually everyone in this room, believe it or not, already has some kind of chronic disease. Okay? It may not be advanced, but you probably have something. Okay? And then you may be able to kind of take care of it. But when you're 40 or 50 years old, you've probably got something, or even 30. You've probably got the beginnings of something. So just prevention alone is not going to do it. There's vast numbers of people who are already ill, and you've got to do it. So the approach that we're taking, though, is that we're more interested in secondary prevention. In other words, stop the escalation. Stop the escalation of disease, do secondary prevention. I'll tell you why that's easier, because then we know who to target, where the biggest bang for the buck will be. And then from that, move on to primary prevention, which is people who are not ill at all, which is much more difficult to find, but that's virtually everybody in many ways. Now, the point that you made about Ayurvedic medicine and so on actually has got a lot of merit to it, but in a different way. In the US today, we're looking at holistic care, and acupuncture, other forms of meditation are gradually being incorporated into post-acute care. And I think it's an essential piece of tackling the cost of healthcare. And I think integrating that approach together with what exists naturally in the society in India for post-acute care, for treating chronic disease, I think that could be a very important element. But somehow integrating them is probably something we should do, and it's an area that we're looking at. Okay.
Should we go to this corner?
Okay, this may not be a fair question, but in the next decade, what do you think will be the biggest revolution in medicine? Either in the product or the delivery or something else?
Well, who knows? There's so many possibilities. I'll take two angles. I think the availability of sort of remote diagnostics and mobile care and all of that type of technology has got to have some kind of an impact. And I don't know exactly how it's going to play out, but that's going to have some kind of an impact. I think associated with that, more and more minimally invasive surgeries. I think a lot of surgeries will become much safer, easier, quicker recovery, less invasive. But if you want to take a clinical area, I think the brain is the biggest untapped opportunity and the biggest need. Because as the rest of the body is being kind of addressed, one is left with mental problems. And the brain is the least understood sort of clinical area, believe it or not, in medicine. And a real advance in that area is probably one that's going to be made. I think there's a lot of focus in that area.
Hi, I'm Rama Kella. I'm a professor here at Berkeley with the School of Information. I have a question for Omar. That is, what you described is a value-added system, if you will. And so I'm sort of curious about in the value chain, apart from hub and spoke, at the spokes, do you also see increasing capabilities, if you will? So that's one. And here in the UC system, when Davis uses telemedicine type of thing, the biggest issue is how do the spokes really learn what's the knowledge base which is coming from the hub, if you will. So a lot of the processing seems important, and I'm sort of curious about your thoughts about that. The second thing is, I was intrigued that you somehow, if you can be cost efficient in producing these in India for the Indian population, why not worry about the world at the same time, and why is that not a smart thing to do?
I think on the second question, that's just a matter of priority. Because if you start by saying, I'm going to serve the world, no one's going to go there. That's not enough, because it's not that simple. You just don't make stuff and people use them. You need a delivery system. And so India is where you can actually impact that, and you can build that. And once you built it, the export becomes pretty straightforward at that point. Okay, to the other point, the hub and spoke have to be connected. And I think I gave as an evolution of the initial system, is that the spoke becomes a center for advanced care. And doctors want that, because these are doctors who are highly trained, and they want to do the leading edge things. They don't want to do the same thing over and over again, because they want to advance themselves. If you build a sophisticated enough spoke, that'll free up enough of their time so that they can do that. So that has to be linked. That can only happen when a spoke is available to treat more kind of standard care, if you like. Then there'll be free time available for leading edge research and so on. Okay.
Yeah, go ahead.
My name is Ram. I exited a digital health startup myself. Since this is the best forum where I have all the stakeholders and of providers right here, I have a question for each one of you. Well, I'll ask the question to Omar. So there are a lot of innovation happening in making medical devices available to consumers these days. Example, companies like Theranos, right? Where people are trying to make medical devices now available for consumers to be able to do some tests and do some preventative care, and get some awareness about the data. So what do you think about these sort of companies that are trying to make medical devices now available for consumers directly? And do you also so you talked about hub, so do you actually currently collect data from the medical devices that you sell into the market yourself, or what kind of initiatives do you have to enable startups offering preventative or digital health initiatives? So that's the question that I have for you. Should I continue my question for the rest, or stop?
One person.
Okay.
We have so many others.
Okay, all right, I'll give a real quick. Okay, please, the next question should be to my colleagues here, okay? But look, in simple terms, I think you've got to differentiate between solutions and problems. Okay, I think what you're describing are different levels of solutions, which have to fit into some kind of a problem framework. Just giving people data is not enough. Someone's got to be there to use the data and treat. Like I mentioned, people enter the healthcare system to get better, not just to find out, or not just to monitor. And so the things that you're talking about are to fit into a system that goes end to end. And I think what I encourage startups to do in the digital world or wherever is to look at what problem they're trying to solve and what's the rest of the infrastructure that's required, and focus in on areas where those other pieces of infrastructure are most developed, so that the innovation that you do can result in a value proposition that's available to a patient in the most rapid way as possible. Otherwise, you'll create some kind of new diagnostic tool for which there's no treatment available. Well, what's going to happen to that? So I think you've got to think through that a little bit. Okay.
Any on this side? No. Okay.
One question for Dr. Satish,
Yeah.
Reddy.
Yeah,
Oh,
go ahead.
there's a question for Dr. Reddy.
This is for Preetha or Omar.
Oh, no.
Okay, well, Satish can answer it too.
Yeah.
Either one of you can answer.
Yeah.
I'm Manoj Goel. I'm invested in a small non-invasive appliance company, medical device that can detect the veins. And it's marketed for India price, done in India. Product is out. Is there at a corporate level, Apollo Hospitals or Medtronics or Dr. Reddy Labs, a place to see if there is interest in your company? They're going and marketing one hospital at a time. So is there at a higher level a place
I
they
think
can
that we have to take that offline,
Okay, sure,
if you
sure.
don't mind. Can you give it to the lady there?
So very interesting talk. I'm Dipti Desai from Thai, and my question was that when you compared healthcare in US versus India, we saw that there were a lot of differences. And in India especially, healthcare is more reactive. It's very fragmented in the sense that the patient has to really go to a lot of different people in order to get the complete care taken care of. And then essentially there's not much record keeping done, or it seems like that. As a result, maybe in the future, it will be very difficult to collect data and improve on the care, and also use that information to improve and bring about new therapies. So is there anything that's happening, or can you comment on how things could change in India to make it more like this? And I understand that it's very different payer and pay. The consumer in India is the end payer, whereas here it's more insurance driven. So how do you anticipate the changes in India, and where do you see it going?
I'm just going to answer half of that. Most hospital systems are now moving to EMR. So they are digitizing, they're collecting data, and they're keeping it. But I'm going to ask Satish to tell us, because the pharma company, they're very stringent with quality, data keeping, records. So I think they would probably have a better answer than me.
No, I think like on the healthcare side, what she said is right. There are protocols now coming in. It's a little bit fragmented today. That's why you probably have that impression. But in terms of record keeping, even in the program that I talked about, which our foundation was doing, the whole basis is on recording things properly, right? It's all fed into server. It's a very digitized kind of a thing. So, but when it comes to the pharmaceutical industry, this is a daily thing that we need to follow, because in terms of compliances, the data recording, the security features, all that has done so comprehensively. That's something which is evolved into quite a fine art in terms of what it is. I mean, of course, in spite of all that, we still have these regulatory actions from the FDA, because that's for a different matter, because to them, the important thing, for example, is the data integrity, right? So the reliability of the data. Issues like, for example, sharing passwords, right? So although there's an SOP written for that, they tend to be, it's like, not willful violations, but something done out of, you can't even call it ignorance. There's an SOP for that, but people end up doing that. And that's something the FDA doesn't accept. So if you see on data, if you see on record keeping, if you see on documentation, it's a very tight thing which pharma companies. Sorry, I didn't.
Back there, that lady there.
Blue, yeah.
This question is for Satish. Through your foundation's work, how many villages and people have you been able to impact, and what would it take to scale that out?
Sure. So it's 104 villages currently, about 2 lakh people, 200,000 people. That's what it is today. So this, like I said, it's in villages surrounding our manufacturing locations, right? So it's something we can still control, in terms of administration, in terms of the resources and things like that. So our attempt right now is to still look at other manufacturing locations of Dr. Reddy's to begin with, and then start expanding into those villages. So we're looking at a place in Himachal Pradesh called Baddi, which is a hub of pharma manufacturing. That's our initial thing, but I think here's the key question, right? So this is done more like a philanthropic effort. So to me, the challenge still remains that in a place like Vizag, your hometown, Solomon, so we would like to figure out some way by which it's a sustainable model, and also get the government completely involved. Today, we can't even have a dialogue with them, right? But over a period of time, we would like to see it transferred to them, maybe the next 3-4 years. Then we'll think of scale up after that. Otherwise, if it's not sustainable, it's not something that we can scale up right now.
You have a mic.
I had a question here. Oh.
May I continue? Okay. Hi, I'm Chetan from EZDI. Excellent presentation from both of you, very inspiring and thoughtful insights. My question is, I love the hub and spoke model that you talked about. Do you envision the spoke can eventually be replaced with artificial intelligence? Because a lot of companies, including Ram over here, my company, we are working on cognitive technologies. And how can we leapfrog the Indian healthcare, just like telecom did, without having to go through the landlines directly into mobile? How can we do the same for healthcare take these very advanced technologies and get the benefits in India?
Yeah, no, I think actually, as long as you do it in phases, I think, I'm just a little wary about, magic solutions in healthcare, simply because of the complexity of the nature of healthcare. And like I said, the liability of a mistake is massive. And so you've got to be very careful with that. Now, having said that, certainly some levels of the screening and basic diagnostics can certainly be automated over time. I mean, I'd argue do that in the US first, prove it out, because it's a much more contained population with generally a higher level of education and more infrastructure available. And then, kind of move it out, because that doesn't even exist here. Now, agreed, the opportunity may be bigger in India, so you might want to disrupt it there. Maybe possible, but starting with that is what I would not suggest. Because then you will create a situation where you have a whole bunch of patients who may be worried, and then there's nowhere for them to go, and I don't know if you're solving anything. But in the progression of how a spoke develops over time, I think a secondary spoke may be one like the one you're talking about, and a primary spoke is one where you actually do some procedures as well, and then a hub is a hub. So I think you just got to do it in phases, but the general thought process, I think, is pretty sound.
Also asked about it. My name is Shubha and I'm from healthcare. What I've seen working in Kaiser Permanente over the last 7 years is there is so much resistance to change even within our own organization using EMR. What are the challenges that you're seeing based on what Dr. Pitroda was speaking earlier? He was talking about 19th century mindsets, 20th century processes, and 21st century technologies. I go to Apollo, receive care from you, and then tomorrow I'm in a different organization due to emergency care or such. What is the policy that is being worked on to support interconnectivity and data integrity, HIPAA, etc.?
Do you want to take that?
You go ahead. Okay. Well, look, I think having interoperability is an important element, but let's start with interoperability just in the U.S. before we jump to between the U.S. and India. I think that's, again, there's so much you can do at one time. I think the resistance to change is partly there because the reasons for change aren't always well explained, and people don't kind of relate to it, and they see the whole thing as a nuisance. And I think that's a big issue amongst US providers, where doctors are actually forced to spend a lot of their valuable time doing things that they find meaningless. I think a incentive system which is focused on patient outcomes is something that doctors can sort of rally around and kind of understand the benefit of. And then building EMR systems that are around that, and then developing it from there, at least in my view, is a better approach than trying to build generic infrastructure, which by the time it's all finished and everyone learns is almost outdated again. And so having a line of sight for improvement of patient care and building IT systems around that, scaling those, and then doing cross-linking is a better approach than building basic infrastructure first, because those things are expensive and the value creation is, there's just too many steps. And then it becomes bureaucratic. So those would be at least our thoughts on that subject.
One last question I have for Satish, and that is, I know how Omar's company always stays ahead of the curve because of, the R&D and investing in technology. But a pharma company, I think, is under so much more pressure to stay ahead of the curve. So how do you do that, Satish?
So frankly, I don't have any role in that, but let me tell you what happens in the company. So if you see in the past, when I even talked about the evolution, right, on how we moved ahead of the curve, it was a vision of the founder, right? So even when we were in the bulk actives business, his sight was on more value addition and then moving further to discovery. So it was his way of thinking and, the vision he painted for the company. But currently, if you see, I mean, of course, I do have a little bit role, but let me put it this way. Our co-chairman and CEO, which is Prasad, who's currently heading the company, he foresees the trends in terms of how things are, and that's what he was always focused on. So I was focused on the operations in the past. So in terms of the kind of management team that we had built up, there's a good mix of people who are based in the US, people who have moved back to India, moved back again here. So you have a very strong management team in the management council who pretty much think the way the company thinks. And that example has been set by the founder. So I would say it's just the culture of the company. That's how it is.
So I'd like to thank Omar and Satish for taking the time to come here and interact with all of us. You've been a great audience, so thank you all for being there. I'd like to call this session to a close because we still have one more session to go. Thank you both very much.